The following is a recorded program of an actual stroke support group. The comments expressed are the personal opinions of the participants, and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.
Stroke.
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 It comes out of the blue, sometimes without warning.
But those who survive it
should never lose hope.
A stroke can be life-changing.
But it is also
A new beginning.
because for all survivors, there is still a beautiful life after stroke.
Hey everybody, this is Christopher Ewing. Welcome to Life After Stroke. And as you know, on the show here, what we do is we basically have a support group and we put it on the radio so that all of you who are unable to attend a support group can actually attend a support group, because you're basically here with the rest of us, just kind of by default. So while we're sitting here in a room, you get to be in the comfort of your own home and eat ice cream out of the freezer and kick back and chill. But we're really glad that you tuned in. We have a very special guest here today. Today we have Dr. Stuart Glassner, who really has an outstanding history and background in dealing with stroke, and he will tell us all about that. And we also have a couple of our guests from last week. So why don't you guys introduce yourselves to the listeners, and we'll go from there.
I'm John Hall, and I had a stroke 3 years ago.
And I'm Gene Sekiguchi, and my stroke is over 7 years ago.
But I'm going to add a little fine print to the rest of it. You know, John is, as you guys may have heard last week, told us about how his son, who is autistic, was the one who dialed 911, and we had our little crying moment, or at least I had my little crying moment. I'll claim it, just because I just think it's just so wonderful to hear that a young man who, in spite of being autistic, is just so outstanding. He's an Eagle Scout and just doing some great things, and he saved his dad's life, and that can't be overlooked. And then Gene, who is kind of modest, he didn't share last week, but I asked him if we could share it this week because I just think it's such an amazing story that he has. Gene was actually the president of the American Dental Association, the president of the American Dental Association, which is just such a wonderful accomplishment, especially given his background and his history, which he also shares. And I'll give you the microphone because I know you might want to say a few things. But Gene, who is Asian American, was actually in an internment camp when he was very young, 3 or 4 years old. Was that what it was?
I was between 2 and 4. 2 and 4,
yeah. And, we won't even get into all of that in the history of things because, what goes around seems to kind of circle back around again. It's just crazy going on. But that's a whole other show. But I just think it's so amazing that, someone who has that kind of a background as a youngster goes on to be as successful as you've become. And then we circle back to our guest here, who, again, is Dr. Stuart Glassner. And, Doc, why don't you tell the listeners a little bit about your history and background and things like that?
Sure. I just want to say thank you very much for inviting me on the show, and it is always amazing to hear people's stories, where people come from, things they overcome.
Absolutely.
So my story is a little different than probably most doctors. I was a bit older when I went to medical school. I was a social worker for a few years, then decided to go into medical school in my early 30s, and I chose neurology. I thought the opportunities were tremendous for helping, plus studying the brain just in itself is pretty amazing. So that kind of got me hooked.
How many years did you take to finally become the specialist that you are?
Good question, Gene. Thank you. So medical school was 4 years. Residency, neurology residency, which I did at University of Kansas, is 4 years. And then I did 2 years in a fellowship in neurocritical care at University of Miami, Jackson Memorial.
And you?
Yeah. So, that was my decade.
There you go. And what would you say is your area of expertise, Doc, when it comes to stroke?
So right now I work as a neurocritical care intensivist, and my main function regarding stroke is to stabilize people, get them treated with some of the necessary interventions, and then stabilize and let the brain heal as much as it can with getting other complications out of the way. For example, somebody comes in with a stroke, as you guys probably heard last episode with Dr. Darflinger, there are some interventions, so some acute interventions. We talked about alteplase, that's the clot buster, and then we also have mechanical retrieval if somebody is eligible for that, meaning if they meet the criteria. I'm kind of in that decision making as well.
So are you kind of like what Dr. Darflinger said last week about him being a plumber? Are you one of the other plumbers, basically? Or?
I ordered the plumber.
You ordered the plumber. Okay, you're the one
and
that calls.
And I take care of the overflow afterwards.
Oh, gosh.
So I don't do any type of intervention in terms of that, but I will try to prevent people from going if they do need it, or support them to go. And when they're done the intervention, we're left with somebody having a new stroke, and that causes changes in the brain. And one of my jobs is to stabilize somebody. As you know, the brain is extremely connected to the rest of the body. So the heart, the lungs, the kidneys in particular take a really big hit with a stroke. The bigger the stroke, the worse the hits can be. So I'm talking about things like pneumonia, cardiac arrhythmias, irregular heartbeats, and again, the kidneys are also in that as well. Additionally, we want to let the brain try to heal. One of the things we have to do is not let it swell as much as it could. The term you may have heard of is edema, cerebral edema. That may sound familiar. So it's just a consequence of the body being injured. So if I hit my elbow really hard, it hurts, obviously, and I don't recommend anyone try that. But after the pain, you'll know swelling. And the swelling wasn't there before.
Sure.
It came as a consequence of the injury. The brain is the same way. It's the body's response to an injury. It starts to inflame. And that inflammation in the brain is called cerebral edema. And because we have the skull around the brain, there's only so much swelling that can occur before we have symptoms.
And so then, are you part of that team that then kind of makes space for that swelling, as we've seen?
Absolutely. We want to, the swelling will, let me rephrase that. The swelling will happen anyway, but we want to manage it as best we can. We don't want other strokes to come as well.
Right.
So one of the things I do is see why the person had the stroke to begin with, and be it an ischemic stroke or hemorrhagic stroke. Best example is with hemorrhagic stroke. If the blood pressure was extremely high, we want to control the blood pressure. If somebody has some clotting disorders, we want to address that to make sure that the bleeding doesn't spread. So I am there to stabilize and also investigate in terms of why this happened. I also start to coordinate, be the quarterback for aftercare. After someone leaves the neurocritical care, I generally don't see them again except just a visit. Sometimes patients will stop by and say hi, or I'll run into them. But I want to get them to an outpatient neurologist, to rehab centers, physical therapists. And I've been pretty blessed. The hospitals I've worked at, I've worked with very good physical therapists. They're on it right away, speech therapy as well. So I'm glad to hear that you each have had that experience. Definitely a very important part of recovery.
So kind of walk us through a little bit. So
Certainly.
we're at home, we start feeling kind of crappy. It's like, okay, we're starting to show the symptoms. Okay, time to get in the car, time to call an ambulance, whatever. We get to the hospital. We then see you. Are you one of the...
Well, it's possible. Generally, there's another team. It could be the ER doctor. So in today's day and age, basically the person that makes the initial decision will actually be EMS. They'll do a score, the LAM score, or they'll call ahead and make sure they're sending the person to an appropriate hospital. Once they get to the hospital, decisions about alteplase, also known as TPA, will be made either by the emergency department doctor. It could be made by a person like myself. It could be made by a stroke doctor. There's a variety of people. Where I work, the stroke team will have the first dibs on the patient, and then I'll get called if there's any questions, and if there's any type of intervention. I know the person's going to be coming to the unit, so I work in concert with someone like Dr. Darflinger, who is a neurointerventional radiologist, or a neuroendovascular surgeon. Doesn't mean necessarily surgery. They could go up through the groin and do a catheter and pull out a clot that way. So I work with a lot of different people.
So you're the one that kind of makes the decision as to what needs to happen then?
Absolutely. I would say after the emergency department, that person will kind of be under my my shield, and I work with other people. Very collaborative effort.
Got it. And then after the decision is made to either go in and get the clot or to kind of watch the bleeding that's happening, if it's a hemorrhagic stroke, and get that all stabilized, then you kind of come back into the picture again?
That's my main focus, is after the intervention is done, is to take the patient to a critical care unit. The last 20, 25 years, there's been a growing type of ICU called the Neuro ICU. You'll see more and more of them. They're really across the world. And the focus is someone like myself who has a smattering of understanding about the brain and critical care pathology and critical care functioning, to take a person and just be dedicated to their brain, but also knowing that systemically there's other things that could happen, because just as an example, someone can aspirate, so that's a risk of pneumonia. I need to take care of that as well. So I would kind of picture myself as a team member.
Sure.
And then when they come to the ICU, I stabilize, investigate, and start to coordinate care.
You are essential. I mean, in the grand scheme of things, you really, you are the quarterback. I mean, you kind of take over the team for someone like us and make decisions on our behalf that really are just so important and so essential, because we're literally handed into your hands, and you're the one that calls in the necessary people that we need in order to kind of get back on our feet and so forth.
And I would say that I work with a lot of good people. I work with PAs and NPs, nurses and nurse practitioners, that are also helping out as well. The physical therapists, the speech therapists, as I mentioned, those people, those providers can't be understated.
Sure.
I couldn't do what I do without people working together. And the other thing that I find, this really, I mentioned having been a social worker. For some reason, I got directed on that path, I believe, because for me, it's very important to talk to patient families and patients if they're able to communicate about what's going on. It's such a tremendous difference, right? You saw your loved one walking, talking, being your loved one a day before, and now, unfortunately, they could be intubated, which means a tube down their throat to help them breathe because they're not awake enough, or there's something physically different with them, mentally different possibly too. So these are amazing changes, and people, rightly so, are in shock.
Right.
And I've been on the other side, like most of us have, and I feel it's extremely important, and my team, that's how I've kind of coached them, to update patient families as much as possible. We do our best to meet with families within 12 hours, sometimes less, sometimes more. It's not 100%, but I think it's extremely important, because if you could picture yourself as a loved one,
Sure.
as a stroke injured person, you don't know what's going on.
Right.
You see a rush of white coats,
Yeah, sure.
lots of people come down the hallway. Well, what's going on? So, and as I said, it's just a matter of good. I feel it's a matter of good care. That's one thing that gets
absolutely.
really kind of left behind, but
Well, because of
been
your
grateful for it,
background,
yeah.
Being in social work, that certainly has instilled in you a sensitivity that may be lost in some of the others. Not that, the doctors aren't sensitive and the nurses aren't sensitive, but you certainly come in to the game, with that added little thread of sensitivity, with your social work background. And what a special blend that all is then, that you do have that added concern and sensitivity to want to make sure that everything is really addressed.
Absolutely.
Obviously, not just our needs as far as a stroke survivor, but the moms and the dads and the husbands and the wives who are sitting in the other room hysterical, wondering what the heck is going on, just as much as we're wondering what the heck is going on. It's really
and I think from my experience, I have no data to support this, just anecdotally, I feel people do better with involvement of families. I really, really do. It's amazing.
Well, we have a ton of questions for you,
Of course.
and we're going to take a quick break, and when we come back, we want to talk about a number of things. I know that one of the questions that's been on a lot of stroke survivors' minds recently has been the amount of depression that they seem to feel post-stroke, and is that common? Is that not? I know that there's a lot of people who have attended some of the support groups that have kind of asked around the room, like, hey, you know what? I've never been depressed before, but boy, I tell you, after this stroke, I've got this depression, and so I know there's some questions for you about that and many more. So we're going to take a break, and we'll be right back. If you have a question you'd like to ask on the air to one of the medical experts heard on the show, you can call the show's studio line at 213-297-8300. That's 213-297-8300. Or you can email your question by sending it to mail@lifeafterstrokeradio.com. mail@lifeafterstrokeradio.com. Hey everybody, welcome back to the show. You're listening to Life After Stroke. I'm Christopher Ewing, and we are speaking with Dr. Stuart Glassner, who is just an outstanding doctor in the field of stroke and has a wealth of information just kind of across the board. We're also here with some of our stroke survivor friends who were with us last week, who I'm sure will have some questions as well. Doctor, you were talking during the break that you have a lot of experience with hemorrhagic strokes, which I don't want to say it's music to my ears, but it's like, what an interesting twist, because, just 8 months ago, I couldn't find any information about hemorrhagic strokes. And so I certainly don't want to take up, all the show, about my personal kind of stroke. I mean, certainly I want you to talk about all forms of stroke, but you kind of initiated during the break that you wanted to talk a little bit more about that. And so, hey, have at it. Because it is being the rarest form of stroke, in terms of the two major, whether it's ischemic or hemorrhagic, and I guess AVMs are even more rare than that. But from a hemorrhagic standpoint, I know that when I was in the hospital, like I said in the previous show, man, I couldn't find anything about hemorrhagic strokes. And when I saw the incidence of the fact that hemorrhagic strokes are the most dangerous and the most tragic and fatal of the two strokes, I thought, my gosh, maybe everybody just died then, that's why I'm not finding anything. So maybe you could talk a little bit about...
Absolutely, I'd be glad to.
I had a hemorrhagic stroke too.
Yeah, they're definitely present. I guess the first thing I want to say about hemorrhagic strokes is I was in medical school and I was in residency, and I was taught 80% of strokes are ischemic, 15 to 20% of strokes are hemorrhagic. That may be true, but where I've been, I've seen that number a lot higher. I trained in Miami. I worked in Jacksonville. I'm now in Fresno and also here in Burbank. And I got to be honest with you, I see that number, that percentage a lot different. 30-40% of patients.
Really? Have you seen them increase over the years, or has it always just been that high from the moment you got into the stroke world?
So that'll lead me to what I was taught and what I believe are reasons for the stroke. Number one is blood pressure that is out of control. Sometimes it's patients that don't even know they have high blood pressure. Sometimes it's patients that know it, but taking their meds is just not enough. And sometimes it's patients are just non-compliant. It's just kind of across the board.
Now, what kind of number, blood pressure number would lend itself to a hemorrhagic stroke?
So it could not necessarily be any particular number, although I've seen numbers as high as 280 systolic. That's the top number on the blood pressure, which is very, very high. So some new numbers have come out about what a normal blood pressure is just very recently. And normotensive is the term, normal tension. And used to be 120, 140. Now it's a little bit lower. We want to get people to less than 130, still having the bottom number be in the range as before. So now that we have a different new normal, so to speak, the numbers that we see, I would probably say a range of anywhere from 180, 190 to all the way to 280. But that doesn't mean if you have a blood pressure of 220 at any moment in time, you're going to have a hemorrhagic stroke. You're going to stroke. Sometimes it is the intensity of how high it is. Sometimes it may just be someone has had high blood pressure in the 190s, 200s for a very, very long time, and the vessels just give out. When my
cardiologist, when he'd heard that I had had a stroke, because when I was released from the hospital, I had to go for, checkups and stuff like that. And he said, boy, when we heard you had a stroke, we were like, wait a minute, your blood pressure was high, but I got guys that are walking in here that should be dead as high as some of their blood pressures. And mine was, like 140 over 90, just kind of let
it's
borderline high. So, we kind of attribute that, because because I'd had these really bad headaches for a couple of years, and I'd had a seizure, a few years ago. So we think maybe it was just kind of a blood vessel in there that was just kind of, a little funky, and it finally just said, screw it, I'm just going to blow up,
Unfortunately, very possible.
So I guess, so I only say all that to say that, when I first heard about hemorrhagic strokes, laying there having had one myself, and hearing that blood pressure is something that, it tends to be the precursor for something like that. But then also hearing that my blood pressure wasn't that high, it was just kind of like 1 and 1 just weren't equaling 2, because it's like, okay, well, if my blood pressure was never really that high, but yet it caused this kind of stroke that's basically comes from the root of having high blood pressure. Exactly what would that number be that someone should really be concerned about? But really, I mean, any number that's considered high or even, I guess, borderline is really...
Yeah, it's a really good point, Chris. And you look like a really young guy. So you come in with a pressure of 140, we would have to look for other causes, which I'm sure that's already been done. So high blood pressure is the number one risk factor for all types of hemorrhagic strokes. Question, Gene?
Recently, the blood pressure standards have been published by the American Heart Association. And simultaneously, they have included the American Stroke Association. So I'm wondering whether the blood pressure numbers are political or as a matter of fact, they are medical.
Interesting.
Yeah, there's been some controversy about that. Absolutely. I would agree. I don't really have a comment on that. I just treat people with normal intensive pressure. And I mean, is it 130? Is it 140? I don't know. People a lot smarter than me have come up with that. But I do know a blood pressure 180, 190, 200. The brain can only take so much. Now, there's other reasons for hemorrhagic strokes too. There's sometimes people are born with clotting disorders. Sometimes drugs can be involved, methamphetamine, cocaine, and unfortunately, I'm in Fresno, I see a high propensity of patients with methamphetamine positive that come in with bleeding strokes. There's other reasons as well, kind of more, I wouldn't say rare, but we definitely see them. Things like reversible vasoconstriction syndrome, some genetic components, that sort of thing. I just do want to add one thing that may help our team here and also listeners. When we talk about hemorrhagic strokes, that's a big term. So if you can kind of picture the word stroke as the biggest umbrella, then you have ischemic strokes, which is due to blood clots on one side, and then you have hemorrhagic strokes. Take that hemorrhagic stroke term and make it another umbrella, and under it are different types of hemorrhagic strokes. There's things like subarachnoid hemorrhages due to aneurysms, things like AVMs that you mentioned before. But the biggest group is intraparenchymal hemorrhages, and that's what we really talk about when people say hemorrhagic strokes. That's what we're really talking about. So the vessels that are around the tissue of the brain have ruptured, and they cause lots of problems. So intraparenchymal hemorrhage is really what most of us mean when we say hemorrhagic stroke. Now, to be sure, there's other types of hemorrhagic strokes. There's the subarachnoid hemorrhage that I mentioned, AVMs, and a few other things that are much less common.
And say this word again.
Intraparenchymal hemorrhage. So that term just means that the parenchyma is the brain stuff, the stuff of the brain, the tissue of the brain. Intraparenchymal hemorrhage.
Now, my hemorrhagic stroke was in the basal ganglia area of my brain. Is that
yes,
kind of in the neighborhood of this?
Yes, that's an intraparenchymal hemorrhage in the basal ganglia. So the basal ganglia are some deep nuclei, deep meaning they're deeper into the brain than towards the surface. And that's unfortunately a very common place for hypertensive hemorrhages. So in fact, that's probably one of the most common places for a bleed, a hemorrhagic stroke, or more specifically, intraparenchymal hemorrhage due to hypertension caused it. So again, those deep areas of the brain, they get vessels to feed, and sometimes those vessels get stiff and they're not able to carry the blood. There's a surge in blood pressure or there's a long-standing blood pressure, and they actually rupture.
Now, is there a basal ganglia on both sides of your brain?
There is. So basal ganglia is just a term that means a group of nuclei in the subcortex of the brain.
Mhm.
So let's make it real easy. The cortex of the brain is the surface of the brain. Going down a little bit is the subcortex, below the cortex. And there's a bunch of nuclei. Nuclei in the brain control different functions of our body. Movement, speech, swallowing, that sort of thing. In that area, there's a group of nuclei called basal ganglia. So there's quite a few, and there's the reciprocal amount on the other side.
I see. Now, are the basal ganglia, are they responsible for function, or are they just kind of chilling out there, just kind of
Absolutely
supporting,
responsible for function. So the brain has a lot of duplication. So in the cortex, you have some areas that can control movement, and in the subcortex, in the basal ganglia as well. So they're all through a very similar pathway. The basal ganglia, if they're injured, generically, meaning just off the top of my head, if you told me somebody had a basal ganglia hemorrhage, I would predict that they probably would have trouble with movement of the opposite side of the body. As we have learned, generally, an area of the brain on one side controls the other extremity. Okay? So motor movement, power, and strength, if someone had a left basal ganglia hemorrhage, I would predict the right side could be weak. It doesn't mean paralyzed. It doesn't mean it may just be subtle weakness, but something. There's other things that the basal ganglia control as well. Sometimes emotion, depending on the nuclei. Again, the nuclei just make up the different groups of basal ganglia. Sometimes speech, very infrequently. Sometimes language, if it hits the thalamus, and other areas of function.
Wow. So
Excuse me, can you
Sure.
now describe where the pons
The
is?
pons, absolutely. So the pons is an area of the brainstem. So the brainstem, as I tell families, it's an area of the brain the size of your thumb, roughly, and it's deep in the brain, deeper than the basal ganglia even. And the brainstem is made up of three parts. There's the midbrain, there's the pons, and there's the medulla. Why are these important? As it turns out, functions of wakefulness are located in the pons in the midbrain. Areas of respiration and breathing are from the medulla. Now, the brain is kind of like a highway. I mentioned before there's connections on the high surface called the cortex to the subcortex, but you have those areas, and how are they going to get to the body? So there's a superhighway that I would call the brainstem. All these areas from the surface, a little bit deeper, they go into the brainstem. So the brainstem then gives way to the spinal cord, and all the nerves go out from there. Now there's some cranial nerves, to be sure. That also happens as well. But kind of think of the brainstem, of which the pons is a part of, as a superhighway. And it's extremely, extremely small. Being in Los Angeles now, we know what that's like, right? Lots of information, lots of people driving, and just a few highways, right? So what happens? If there's an injury there, if something happens, an earthquake, some kind of damage, there's going to be a backup of traffic, and things are not going to be as they were before. So very similar to an injury in the brainstem, the pons. All that information is interrupted. Now there's different grades. Not every pontine stroke is the same. But certainly a brainstem stroke is extremely concerning. And as it turns out, a pons hemorrhage is also very common for hypertensive hemorrhages.
is that the kind of stroke you had, Shane?
They can't find my they cannot find my stroke. So I think it's probably a good idea to just call an ischemic stroke.
Ischemic stroke.
Because then there'll be 80%, right?
They said it was in the pons? They think so. Very small stroke in the pons.
Does plasticity work in the pons?
Absolutely. So your question is, does plasticity occur in the brain?
No, in the pons.
In the pons, yes. Excuse me. So plasticity just means the ability of an area to recover. not the best definition, but for the brain, can the brain recover function if one area of control has been hit? And there's a lot of, again, I can't think of the best word, a duplication and triplication in the brain. The brain makes every effort to try to heal itself. If the stroke or the injury is at a certain threshold, if it's too big or if it's just in the most strategic spot, that, so far as we know, is not able to happen. That's why, for the most part, if somebody has a stroke, the stroke is not very huge, and it's not, say, in the brainstem per se, people generally get somewhat better. There's some improvement after a stroke because of plasticity. It can take a very long time. Our understanding of this is pretty much still in its infancy, despite having had quote-unquote modern medicine for the last 150 years. We still have a very limited understanding of that. Some people may argue, but that's okay.
And because of, all these years of this data to go by, what do you see, this is kind of going back to what we had talked about a little bit earlier, in this increase of hemorrhagic strokes, that,
Sure.
The discrepancy in the numbers and the ratio and the percentages?
So as I was going off tangent there, get back to your original question. So I feel it's a lot of it can be situational. It can also be regional. But I think the increase in drug use, unfortunately, has definitely played a part, especially in younger people. As I said, methamphetamines and cocaine, what they do is they help worsen the high blood pressure.
How about the amide recently?
Say it again, I'm sorry, Gene, what was that?
How about the drugs that I think are called amide? They're like they're under the rules of prescription, but I think they're overused for pain.
Oh, you mean opiates? Okay, yes, absolutely. So methamphetamine and cocaine are not opiates. They're actually in a different class. But opiates, do they cause a high blood pressure? They probably don't. Pain, however, that's another thing to consider, is that we are in a culture where we have a lot of pain, unfortunately, right? A lot of patients with lower back pain. And as you know, pain can cause hypertension. It can cause, because it hurts, right? Stress can cause a lot of increase in blood pressure, so that is a risk factor. Opiates themselves can actually lower blood pressure. They're not used to treat low blood pressure, though. It's just one of their side effects, because you're dropping someone's pain level and just the nature of how that drug works.
Interesting, so interesting. Well, Doc, we're going to take a little break. When we come back, we're going to talk about pain in stroke. I know that John's got a question about that, and I'm sure some of our listeners do too. And then we're also going to talk about the other stuff we had mentioned in terms of depression and stroke, and then also the number of young people that you're seeing that are coming in with stroke, even kind of non-drug related even, but just the uptick in that, it seems like that's starting to kind of increase too. So a lot more questions, and everybody sit tight. We'll be right back. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing, and I tell you, during the breaks, that's when we get so many more questions. Just more things have come up here. One of them is, what did you call it? Safety net hospitals?
So during our break, Gene had a really good question, and so did Chris, about kind of piggybacking what we were saying before, is why we're seeing more stroke in younger people, especially hemorrhagic stroke. One thing I wanted to add was differences in our healthcare system, especially over the last few years, people having a lack thereof. So even if they're told, you've got high blood pressure, you don't have insurance, what are you going to do? So that can also demoralize a lot of people.
So then they don't get help, they don't go for checkups and things like that. And
unfortunately.
Part B. They do not get Part B, which is the extra premiums for drugs.
Yeah, I think and this is for another podcast, but some interesting decisions coming out of the White House. Let's just leave it at that.
Yeah, I got you.
But as a provider, we definitely see it.
Sure.
As a former social worker, you will know about that. other providers do not.
I think other providers do, actually. I think we all kind of see it.
But it was interesting during the break you said, you don't even want to know if somebody has insurance or not.
Yeah, so a question that John or Jean was asking me is, do you see a lot of hospitals that may not take every type of patient? And there's some, what we'll call them concierge hospitals, sure. But I think most people want to help out. In terms of my own experience, for some reason it's just worked out this way. I've landed at what I would call safety net hospitals. These are hospitals that take anybody and figure it out later on. I myself don't really want to know what somebody's insurance is. I just don't want to know that. It doesn't play a part in the care. So aftercare it could, but in the acute phase, I just personally, and again, you may find people that disagree with that. That's okay. I just don't really want to know. I want to treat people, everyone's a VIP, put it that way. That's how I'd want to be treated.
Yeah, sure.
How large of an area do you serve at a Fresno hospital?
How large of an area is the stroke part, or? I'm part of with the neurocritical care. So we have about 20 beds in the hospital, and the hospital's about 450, 500 beds. I could be wrong. 450 beds, yeah.
You must serve a very large area.
Right, Fresno County and surrounding areas is pretty large. I didn't know much about Fresno before I got there, and it's bigger than Sacramento. I didn't realize that.
Now, I know John had a question about pain.
Certainly.
My back pain is better now, but before the stroke happened, pain every day. But I got help from it, but it was bad, and pain is not bad now, but it's doctors help too.
And you've taken some medications and some physical therapy and things of that nature. So one of the changes that happens if somebody's having a stroke, and again, it also is somewhat dependent on where the stroke is, but I'll use the example of a patient that has a stroke, be it ischemic stroke or hemorrhagic stroke, that's affected their extremity function. It's not just the power. We think of extremities. Well, can you lift your extremity? Can you move it? It's also the tone of the extremity, muscle tone. So this is where we get into terms like spasticity.
Yeah, hello.
Spasticity, the way I like to think about it is your muscles are kind of wired and they're not able to relax. And that can be very painful.
Tell me about
very,
it.
Very painful. We get an amen here.
Amen.
Unfortunately. The reason for that is because the different pathways, this is what we feel we know, different pathways that are injured, and those pathways that allowed that tone to be quote unquote normal, spastic voluntarily and then to be relaxed, that pathway is actually injured, unfortunately. And the spasticity is a very big problem in post-stroke care, post-acute stroke care.
Does that pathway ever kind of, fix?
I think it depends on how severe the stroke is. Now, again, the pathway itself may be injured, and we know that the body and the brain is always trying to come back to a balance. Sometimes we don't see it, sometimes we do. There are some medications, this being the land of Western medicine, right? You gotta have medications. Baclofen and things like that, and there's Robaxin, Flexeril, Xanaflex, things like that can kind of relieve that. Sometimes they're successful, sometimes they're not, but it is a very big problem.
One thing I've noticed when it comes to pain, and I've read a lot about this, is the fact that it seems like a lot of the pain post-stroke centers in the shoulders. And that's kind of another thing I would ask you from a rehabilitation standpoint, as I'm sure probably a lot of listeners are probably dealing with this, is range of motion and the importance of maintaining range of motion in spite of the fact that you have pain, which would kind of lend itself to you not wanting to move too much because it hurts to move. So it's kind of like, you end up throwing the baby out with the bathwater in the sense that you should move your arm, but it hurts to move your arm, so you don't want to move your arm too much because it's going to hurt. So as a result of not moving it because of the pain, that actually just lends itself to an increase in loss of motion because you're not moving it enough. because you don't want to hurt.
And you can get contractures
Sure.
and things of that
Mhm,
nature.
mhm.
So in the ICU, that's what I deal with predominantly is patients in the acute phase. And even there, with physical therapy and with the nurses, we'll get that arm moving.
Mhm.
Even if they're not able, they meaning a patient not able to move it on their own. I think that movement is extremely important. We work with coordinating care for rehab. I don't do a lot with rehab after they leave the ICU,
Mhm.
even though you can tell, though, someone is going to probably deal with some spasticity.
Mhm.
Early on, we don't treat spasticity with baclofen or Botox simply because, well, with baclofen, it can alter someone's mental status, and we
Mhm.
want to be sure we don't have that problem. Someone's a little more stable, maybe a few days after the stroke, then we would consider some baclofen, Xanaflex, something like that. Muscle spasms are a problem too, not just
Oh, yeah.
spasticity,
Oh,
but
well.
just the tightness in the muscle. So you've been walking around for 30, 40 years, and now you have a problem where you have one limb that's different. Your body is going to torque and twist and try to compensate.
Mhm.
That could be where some of that comes from as well, not just central, but also just postural.
Does the spasticity ever kind of just cease? Does it just say, okay, I'm out of here? I'm
I think
done?
it can be treated based on my experience and what I've seen in patients after stroke, because I did have clinic before, back when I was in residency and fellowship. Sometimes it's controlled with medications and with physical therapy. I don't know that it ever goes away if it's been very severe. It's a good topic, though. Maybe a future show we
Yeah.
can bring on a physical therapist and a neuro rehab specialist. It's very interesting stuff. The more people we bring to the table, the better.
Sure. Oh, well, that's what the show's all about, and Lord knows we've got a list of people we're going to be bringing on in
Absolutely.
future episodes.
Very good questions, and that's very important for listeners out there.
Yeah, absolutely, absolutely. I want to kind of turn a corner because this is something else that I've heard that other people talk about in some of the support groups that I've attended. Thank goodness I don't have to deal with this because I had enough on my plate as it is between the spasticity and the central post-stroke pain syndrome and all of that.
I understand.
Depression. I understand that there's a lot of stroke survivors that find themselves dealing with depression post-stroke.
Absolutely.
What happens in the brain that makes that kind of kick in and happen?
So things are still a little controversial, but it's been studied. There's been papers back in 1984 that have described it, but generally, I'm sure even before that, people had strokes and they've had personality changes or just depressed moods. So it's something that the medical community has been aware of before. So the theory is that there's different parts of the brain that are important for emotion. Could be related to the handedness of the person as well, right-handed, left-handed, linked to the language and the speech centers as well. But we do know that there's different parts in the brain that are sensitive for emotion. So if those areas could be hit by a stroke, it's possible that someone's mood or personality can change. We see this a lot. You may have heard the term, quote unquote, being frontal. I don't know if you've heard that term before. Someone is, quote unquote, frontal. That means there's an injury in the brain. They lose impulse control in the frontal lobe. We see that in patients with traumatic brain injuries. Hit their head, there's blood there, and their personality has shifted. So we know that personality can be changed by an injury to the brain. And going back to stroke, areas what I was reading, mostly in the left part of the brain, an injury there can cause some personality changes, parietal lobes, different parts of the basal ganglia, things of that nature.
John, you got a question?
I had PSD, and it's gone now
That's awesome.
with the stroke.
Good news.
Wow, the PSD went after you had the stroke? The stroke made the...
Interesting.
Wow.
Yeah, but it's
Wow.
bad for me now, but it's
Wow.
done.
Huh. So the PTSD was from being in the service and in the Army and everything?
And the Army, and it's done now. But it's done, but stroke happened to me, and it was bad news. Yeah.
Well, that's interesting.
Very interesting.
Could you
That's cool.
comment on why suicides have gone up? Is that related to depression?
So suicides due to depression in stroke patients or just generally?
But generally, also strokes.
Well, that's a good question, Gene. In terms of, let me talk about the patients with stroke first, and then I think we can expand that. We know some of the studies that have been done. Sometimes studies are done, they're repeated, other people do other studies, and then eventually some other group will do what we call a meta-analysis. They look at a series of studies, randomized controlled trial or smaller studies, and they'll get an opinion from that. And on post-stroke depression, there's been quite a few meta-analysis, which quite honestly have done the work for us, right? They look at all the other studies and they'll give an opinion. So what these meta-analysis have said, risk factors for post-stroke depression have to do with things that are not that surprising, unfortunately. Size of stroke, location. Also, if somebody has emotional support, family support, lack thereof puts someone at a higher risk of depression. The numbers say 33% of all stroke patients that survive are diagnosed with post-stroke depression. So the suicide part, an awful situation, could come from just that feeling of hopelessness. In our country, in our world, you know, with lots of pain and lots of other concerns, lack of health insurance, lots of stresses, that can contribute as well. It's also coincided with the increase in opiate addiction as well, unfortunately. That's generally in our culture. Going back to stroke, I think those risk factors are pretty reasonable, and to me, they kind of make sense. The larger the stroke, the more area that can be affected, less support. That kind of goes back to what we talked about earlier, that I feel patients do better the more families are involved. Okay. Also, the magnitude of disability, not being able to walk again, that's depressing. Right? That just only seems unnatural. And again, I think depression can be somewhat natural as well. I mean, it would make sense to be depressed, to grieve, right? I think post-stroke depression becomes a problem when after that grieving period, quote unquote, a natural grieving period, it continues and it becomes debilitating.
Right. Well, to all of our listeners, definitely, if you sense that you're more depressed than you were, certainly pre-stroke, but that also that now that you are kind of post-stroke and you're kind of finding yourself in kind of a hole even more than you think is normal or reasonable, definitely reach out to your doctors and talk to them about it. I mean, there's no shame in the game. You gotta look into that and get some help and stuff like that. Don't be ashamed, and certainly don't be embarrassed to bring it up. But it sounds to me like it's something that is very common in stroke survivors, and so kind of don't question it. Don't shuck it off. Look into it. We're going to take another break, and we'll be right back. Hey, this is Christopher Ewing with a Life After Stroke health tip. Now, you always hear people ask the question, how did we ever live without cell phones? Well, today, our cell phones can actually help us live. Whether your cell phone is an iPhone or an Android phone, if you have a previous medical condition, and especially if you're a stroke survivor, then you absolutely want to have a medical ID on your cell phone. Now, a medical ID is a special link that sits right on the home screen of your cell phone, where someone like an ambulance driver or a doctor or any first responder to any medical emergency that you may be having can find the important medical information that you want someone to know if you're not able to tell them yourself. Maybe because you've lost consciousness, or you're having another stroke, or maybe you're just unable to speak or remember the information for whatever reason. All someone needs to do if you're having an emergency is click on the medical ID link on your phone, and there they can see all the important information that you've listed there, like your name, any prior medical condition that you may have, any medications that you may be taking, as well as the phone number of the person who should be notified if you're having a medical emergency. Now, on most phones, the Medical ID app is already on your phone and ready to be set up. And if you don't see a Medical ID app currently on your phone, then all you have to do is go to Google Play or the iPhone App Store and download any Medical ID app that you choose. And best of all, most of the Medical ID apps you can choose from are free. So having a medical ID link on your phone is super important to have. And what's even cooler is, in an emergency, the first responder can even access your medical ID info, even if your cell phone is locked and requires a password to open it. If you need more information on where to find a medical ID app and learn how to activate it on your phone, or if you have a really cool health tip that you'd like to share with others, just go to our website, www.thestrokechannel.tv. I'm Christopher Ewing, and this has been a Life After Stroke Health Tip. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing. We are talking with Dr. Stuart Glassner. And, Doc, we had touched on it a little bit in terms of stroke and drug addiction, and how, you're seeing younger and younger people, come in with strokes and, be in their 20s. And, at least I've seen them at some of these support groups. I mean, young guys that are just, kind of dealing with this. And you had mentioned it up in the Fresno area, which is where you are primarily based. You see a lot of that up there. Talk a little bit about that.
I think addiction in general is just a devastating condition. It takes no prisoners when it starts to rear its head, and physical health is just one aspect of that. I mentioned before about hemorrhagic stroke and seeing methamphetamine use, cocaine use back east as real contributing factors. However, both of those drugs can also cause ischemic stroke. They can actually cause the vasculature, the vessels in the brain, to open and close. And that's not a good thing. So it's documented, we see it, but more commonly is hemorrhagic stroke. The bottom line is that those type of drugs are not good for the brain, and generally not good for the body, not good for the soul. So it's just an epidemic we have out in our world for various reasons, and there's no judgment here, believe me.
Sure.
If that's something that you're struggling with, I would support you in getting some help.
Absolutely. Do you think more should be done, I don't want to say like at a grassroots level, or, kind of like at a high school level or a college level in terms of talking about some of this stuff? I mean,
addiction,
again, you think of stroke, and again, you think of the old lady down the street. You don't think about it happening to somebody in their 20s or in their 30s and things like that. But, it's visiting there. And so maybe we could benefit from kind of reaching into that age group.
Absolutely. I think just having good, healthy habits can go a long way. I remember being in medical school and being given a book on what we call pathology. Pathology is why things go wrong. The book was about this thick. For those who are not seeing, I'm making the proverbial 4 or 5 centimeter with my finger, my thumb and finger.
2 phone books. Yeah.
If you took out drugs, you took out alcohol, overeating, that probably goes to
a pamphlet.
About pamphlet size. So there's certain things that we can't control. Genetics, we unfortunately or fortunately, we come with what we're born with, right?
Yeah.
For the most part, so far as we know, leaving CRISPR aside. We have other things, our gender, for the most part.
Right.
There's risk factors in males, risk factors in females. Our parents, our family lineage, kind of more again with genetics. Some environmental factors, but there are some things that we can modify.
Full control.
Wouldn't necessarily say control per se, but we can at least modify. Diabetes, smoking, hypertension, all those are very big risk factors. Obesity, for sure, absolutely. Sleep apnea has been a big thing with stroke over the last, really documented over the last 10 years. It's still somewhat of a question mark, but I think it plays a part. So. But life is such that in our world there's lots of stresses, and it's just how we deal with things. It's just how we deal.
Yeah.
I think the fact that we live to be older has a lot to do with it.
Excellent point, Gene. We do have a population that's growing and living longer, so far as I know, and more conditions have come up. Some of the vasculature gets a little bit maybe weaker is the terms, or more susceptible to some of the other factors that we have with diabetes and hypertension, whereas maybe we didn't have that before. So it is, make no mistake, stroke is a problem citywide, nationally, worldwide. I would also say, and to your point of community action, is what to do if they see somebody with a stroke.
Mhm.
So I remember being in residency, and that wasn't that long ago, maybe about 10, as you said, 10, 15 years ago. And I remember coming to the emergency department because there was a stroke code overhead, and I would see a man or woman sitting there, and I would say to the family or to the patient, if they were able to talk, what happened? Well, we had weakness in the arm and slurred speech. And when did it start? About 2 days ago, 3 days ago.
Yikes.
And that was really common. It sounds amazing now, but if someone has heart pain or chest pain, anything with pain, people are going to go to the hospital probably a little quicker. But sometimes I didn't see that with that urgency with stroke.
Yeah.
And you probably have seen a lot of public service announcements with stroke more and more over the last few years that, if you see the signs of slurred speech and weakness, get to a hospital. And that's because, as those public service announcements say, time is brain.
Fast. Sure.
Yeah.
We want to intervene. So again, I see cases of delay less and less, but they're probably still there. I think also the male persona of being perceived as weak with the stroke, can't move my, I'll sleep it off, and I think that plays a part too, unfortunately. So community awareness that if somebody sees this not just in themselves but in another person, they're slurring speech, they're weak, they're stumbling, they just want to get to a hospital, even if they refuse, right?
Sure. I mean, especially as common as stroke is, and now if it's dipping down into the other demographics, the younger crowd, stuff like that.
It is, yeah.
I mean, man, we all need to be on our toes because we're going to, no need to keep looking for grandma. I mean, it's getting down there to the other age groups where it could hit anybody.
I had a stroke, and I was young and able, and I had a stroke, and it takes everyone
Right.
now. And I was a lieutenant colonel in the Army, and it was bad stuff, though. But I was at a fork in the road, and then I had a stroke, and I turned it off, and I was out. And Evan called 911.
Oh, buddy.
Amazing that your son did that. Saved your life.
Absolutely. It's really amazing, really how much, as you think about you being in the social work too, prior to you becoming a doctor in stroke and things like that, how much stroke affects not just the stroke survivor, but also the family. I mean, the family basically has a stroke almost as much as we do in the grand scheme of things. That they're seeing their loved one. I mean, it's kind of like if my mom stubs her toe, I'm going to say ouch, because that's my mom. I love my mom. So it's kind of the same thing where, we as stroke survivors go through it, but I'm sure in your social work, prior to becoming, a doctor and things like that, you really saw how the family would really, go through some things too.
That's an excellent point, Chris. And before, when we were talking about post-stroke depression, my thought was, it's not just the patient, it's the family member. Because now, depending on the severity of the stroke, now they're a full-time caregiver.
Right.
They didn't expect to be.
Sure.
And they expected to be a spouse, and
Sure,
now they're taking
exactly.
care. It takes a lot of energy and a lot of work to take care of another person.
Right.
And there's a grieving process with that. I wish there wasn't situations like that, but the reality is that stroke happens, and patients' lives are just upended.
Right. I know I want to have you come on again, on another show where we can really delve into that a little bit, because, I'm so passionate about the caregivers. My mom, who is just, she's the salt of the earth, and I certainly could not have recovered nearly as well as I have had it not been for her. And, I just really am very, very sensitive and passionate to the fact that the caregivers that we have, they enter our world as moms, dads, brothers, sisters, husbands, wives, and as soon as stroke hits, they immediately, by default, now become doctor, housekeeper, driver, sometimes bedpan dumper. I mean, they really start to have to take on other roles that they never even imagined. And it's got to be very tough for them. It's really got to be tough for them.
I'm into that.
Yeah.
I would agree with that.
Yeah. So, at some point...
you know that much better than I do.
Yeah. Fortunately, I praise God, I've kind of dodged a couple of big bullets in terms of my stroke and things like that. I mean, mine just kind of, centers around pain and, some, mild numbness and sensitivity and stuff like that. But one of the reasons why, I'm so passionate about doing this show is because, I've developed friendships with other stroke survivors who I meet at support groups, who I met in rehab. I was in the rehab hospital for a month, a little over a month. I was over in the hospital overall a month and a half. And, you see the faces, you see the hearts, you see the families of my kindred brothers and sisters now. And through laying in the hospital, knowing that, I'm in a hospital with 7 stories to it, and on every floor there's stroke survivors just scattered through here with various situations and ailments and everything else. But now, as I sit here today, one of the reasons why I wanted to create this show is because on the other end of this microphone, there's hundreds of thousands or more that, are going through the same thing, who may not have, a Dr. Glassner to run some questions through, or to talk to, or hear some insight from, the physical therapists and the occupational therapists that we'll have on the show and things like that. I mean, there's some people who just don't have access to the type of information that they really need to try to, navigate through this craziness.
Thank you for providing this service for them, because it's absolutely needed.
No, the thank you needs to go to someone like you, because we are in this 24/7, 365. I mean, we're stroke survivors by default. You're someone who could have done anything with their life, doctor, but you chose to help people. You started in social work, and that wasn't enough for you. You wanted more. You wanted deeper. You saw a need that needed to be filled, and you went there with it. I don't get me started, because I'm a crier, and I cried in the last show. I've said to myself, I'm not going to cry in this show, but I really, I got to go here with it. It's my show, so I'm going to say what I want to say. It never really hit me just how selfless people could be, until you look at how much of a need you might have. I mean, all of you stroke survivors listening to me will totally understand this. There is not a stranger feeling to have than to lay in bed or sit in a wheelchair and stare at a body part that you've always been able to move your entire life, and now all it's doing is staring back at you. And you're sitting there trying to figure out, okay, make it move, do it. Okay, I'm crying. I'm going to give a shout out to Mimi. And I'm going to give a shout out to all my peeps over at California Rehab.
Absolutely.
You guys know who you are. Amanda, Moses.
Some pretty hard stuff.
Amanda, if you're listening to this, you know what I'm thinking. Amanda is one of the OTs over at California Rehab, and for the first 2 or 3 weeks of being there, I stared at my left hand countless times. Wanting to see my fingers move at all. Just a little bit. Something. And every single day in that hospital, great care there, great schedule, every day physical therapy, OTs, speech therapy, just constantly all throughout the day. And every day, these people are constantly drilling us to try to help us get our lives back. And through one of the exercises, she had my arm on a table, and we were, put it on a towel or something to get it to move back and forth. And every time I went to push the towel, we noticed that my fingers were starting to close for some reason. And I was like, wow, that was kind of wild. I hadn't seen that before. And she was like, do it again. So I did it again. And so it was like, well, let's see if you can do it without having to move your arm. Let's just sit here and just look at your hand and try to close your fingers. And that was the first time I saw my fingers close since I'd had my stroke. And I looked at her and I almost choked her because I turned and hugged her so hard I thought I was going to suffocate her. Because, you don't realize, again, when you've looked at body parts of your body for years and you've always been able to make the move without even thinking about it. But yet, something like as devastating as a stroke comes along and it's like, wow, I'm like literally looking at my hand right now or my foot or my leg and that thing ain't moving. I mean, I'm doing everything I'd always done all my life to make it move, and now I can't make it do anything. That is so amazing. And just the fact that, and I'm now circling back and I've probably edited out about 2 minutes of crying, everybody, so, but and this is my point, someone like you could have gone into whatever line of work you wanted to. Someone like Amanda, someone like a Moses, Mimi, my buddy over at California Rehab, when I was trying to learn how to walk again and I couldn't take more than 2 steps, and she said, tell her what to do, Chris. Tell her what to do. Tell her what to do. And, that's kind of become the mantra. It certainly was my mantra early on, was telling parts of my body what to do when it wouldn't. My point is that, all of you, like yourself, doctor, out there who have dedicated your life to helping all of us, like Gene and like John. John's nodding his head, amen, in my corner over here. I know, you don't have to do this, You could have stopped at being a social worker. You didn't even have to go into social work, But it's really been amazing to see how selfless people can be. And you don't really realize it until you realize how needy you are and how helpless you are. That when you are your most helpless, it's then that you need the most selfless. And when those people come to your rescue, it is like a breath of fresh air mixed with gold, mixed with, the coolest, greatest bowl of ice cream and everything else you could have possibly imagined. And so anyway, that's my little rant on that. Were you going to say something, John?
No. Michelle, the therapy guy, Michelle, speech guy is good one for me.
Yeah. And I don't know what I'll do with it. I may end up cutting out the last 4 minutes of this, but it is really just it's a crazy thing. I remember saying in one of the support groups I went to, stroke is kind of like being dropped into a foreign country where you don't know where you're at, you don't speak the language, you don't even know how you even got there, and you're put there and it's like, okay, now go live. Go feed yourself, go communicate, go try to survive. And it's like you're there with parts that don't move, and you've got to try to make some sense of it all, And so it's really kind of amazing. But I guess this is my long-winded way of saying thank you to you.
And I really support your mission
for dedicating what you do to helping people like us, because we need it to the biggest degree. And certainly on behalf of everybody who's been listening to this show today, I definitely thank you for your insight. I'm just...
Chris, I really support you in your mission and what you're doing here. It's amazing. And the other gentleman, thank you for being a part of it.
We definitely thank you for coming on the show today. And we've been speaking with Dr. Stuart Glassner, and everybody listening, glad you guys could be a part of it. If you If you don't have a stroke support group in your area, I mean, obviously we're here for you, but definitely if you don't have one in your area or don't know of one, definitely look for one. If you've looked for one and there isn't one, then I encourage you to start one of your own, because there's a lot of people out there, I'm sure, that would want to be a part of it. And yeah, so there you go. So anyway, I appreciate you guys listening, and until next week, remember that there is still a beautiful life after stroke. This has been a recorded program of an actual stroke support group. The comments expressed are the opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.